All right, let's dive into the basics of inflammation. And it's a fundamental concept in pathology, and understanding it will help you differentiate between inflammatory changes and dysplasia.
So what's the key difference again? I'm still a bit fuzzy on that.
Great question. Inflammation is the body's response to tissue damage, while dysplasia involves abnormal cell changes. Today, we'll focus on acute inflammation, right? A rapid response to trauma, ischemia, toxins, or infection.
Got it. So what defines acute inflammation?
Acute changes include vascular congestion, edema, fibrinous exudate, tissue damage or necrosis, and the presence of neutrophils, often called polys. These are key indicators.
Looking at the image, I see granulation tissue with loose myxoid areas and prominent capillaries. How does this relate to acute inflammation?
Excellent observation. Granulation tissue is part of the healing process post-inflammation. The thickened stroma around capillaries, highlighted in pink, supports rapid repair. Neutrophils are often present here, reinforcing the acute phase.
So neutrophils are the hallmark of acute inflammation? I think I get it now.
In biopsy samples, we see clusters of cells indicative of inflammations. The pinkish purple staining highlights cellular changes, showing how tissues respond to damage or infection. All right, let's discuss what happens after an acute injury. The body can respond in several ways. It might heal completely, develop fibrosis or scar tissue, form an abscess, or enter a chronic inflammatory phase.
So the outcome depends on the severity and type of injury. But how do we tell if it's healing properly versus forming scar tissue?
Excellent question. Signs of recent damage include granulation tissue, hemosiderin, lipid-laden macrophages, and fibroblast proliferation. These are key indicators of the healing process.
I remember granulation tissue being mentioned earlier. Can you describe what it looks like? I'm a bit fuzzy on that detail.
Granulation tissue has a watery or myxoid appearance with sparse fibroblasts and a proliferation of inflammatory cells and capillaries. The capillary endothelial cells become plump and prominent, almost resembling epithelial cells.
That's interesting. So it's like the tissue is regenerating, but still has a lot of inflammation. And I wonder how that balances out for proper healing.
Looking at figure 3.4, you can see the dense pink collagen fibers replacing the original structures, which is typical of a dermal scar. This process displaces subcutaneous fat and adnexal structures.
I see. So the granulation tissue eventually transforms into this dense collagenous structure we call scar tissue. But what about those lipid-laden macrophages mentioned earlier?
Those macrophages engulf dead cells and debris during the inflammatory phase, which is crucial for clearing out damaged tissue to make way for repair. In figure 3.5, you can see histiocytocytes with pale folded nuclei surrounded by light pink cytoplasm. These cells are part of the inflammatory response and help in tissue repair. All right, let's dive into this fascinating topic about biopsy site changes and scar tissue formation. When we talk about biopsy site changes, we're referring to evidence of a recent procedure where the body is healing. This includes several key features: fibroblast proliferation, which is the early stage of forming scar tissue; foreign body type giant cells, suture material, foreign macrophages, fat necrosis, and inflammation.
Wait, I need to make sure I understand. Fibroblasts are the cells that produce collagen during healing, right? So that when they proliferate, it's like the body is laying down the foundation for a scar.
And it would be on similar to this. In the early stages, you'll see fibroblasts actively producing collagen. This is part of the granulation tissue formation, but biopsy site changes have a more solid appearance compared to granulation tissue, as seen in figure 3.3.
Got it. So the key difference is that biopsy site changes are more solid looking because they've started to form scar tissue. But what exactly defines scar tissue?
Scar tissue is characterized by a dense, thick layer of collagen replacing the normal structures. In the skin, this appears as a homogeneous tank layer of collagen without any hair follicles or sweat glands, which are typically absent in scar tissue.
So in figure 3.4, we're seeing a dermal scar where all the normal skin structures have been replaced by this thick collagen layer.
All right, let's dive into figure 3.1 and figure 3.2. These images illustrate the process of inflammation and tissue repair. In figure 3.1, we see an example of acute inflammation with abscess formation.
So what exactly is happening in this figure? I see neutrophils mentioned. Aren't they a type of white blood cell?
Exactly. Neutrophils are indeed key players in the immune response. In figure 3.1, we observe collections of these neutrophils forming an abscess 7. This is a localized collection of pus, which is our body's way of isolating pathogens. And
what about the extravasated blood too? Why is that there?
Good question. Extravasated blood refers to red blood cells that have leaked out of blood vessels into the tissue. And this happens because the capillaries become more permeable during inflammation, allowing immune cells and fluids to move into the affected area.
I'm trying to visualize this. So the capillaries are prominent which makes sense since they're dilated and carrying more blood to the site of inflammation.
And then the increased blood flow, you know, and brings in more immune cells and nutrients to fight off pathogens. You'll also notice fibrin accumulation, and it orders this fibrin over 6.27 diacetyls. Also notice fibrin accumulation, which forms a scaffold for tissue repair and helps contain.
The inset shows a mix of different inflammatory cells: plasma cells, neutrophils, eosinophils, and lymphocytes. Why are all these cells present?
Each type of cell plays a specific role. Neutrophils are the first responders engulfing pathogens, and eosinophils target parasites, while lymphocytes provide adaptive immunity. Plasma cells secrete antibodies to neutralize threats.
Okay, that makes sense. Now moving on to figure 3.2. Granulation tissue is described here. What's the significance of this?
Granulation tissue is a hallmark of healing. It's characterized by a loose myxoid background, rich in fibroblast and inflammatory cells. The prominent capillaries are essential for delivering nutrients and removing waste during the repair process.
So I notice it mentions plump endothelial cells and thick walls of the capillaries. Why is that?
The endothelial cells lining the capillaries become more active during inflammation, which can make them appear plump. The thick walls are a result of increased blood flow and pressure in the area.
And what about the pink halo around the capillaries? That seems unusual.
The pink halo is due to the stroma or connective tissue surrounding the capillaries. During inflammation and repair, the stroma becomes condensed and thickened, giving it a distinct appearance. All right, let's dive into chapter 3, focusing on infection and inflammation. Today, we'll explore two fascinating cases: cytomegalovirus infection in a Gischenschon, like Giardia.
Professor, could you explain what CMV looks like under a microscope? I'm having trouble visualizing it.
Great question. Here's figure 321 showing CMV infection in an endothelial cell of the gastrointestinal tract. Notice the arrow pointing to a dense reddish nuclear inclusion with a clear halo and purple chromatin, hallmarks of CMV.
So that red arrow highlights the virus presence in the nucleus. I'm curious about how this affects the cell.
Exactly. CMV alters the host cell's nucleus, disrupting its function. This image illustrates how the infection manifests at a cellular level.
Switching gears, what about Giardia? I remember it's a parasite in the intestines, but I'm not sure how it looks under a microscope.
Looking at figure 714, Giardia appears as a flat, crescent-shaped organism when viewed from the side, and like a flounder with a tail from above, it clings to the villus luminal surface without causing much inflammation.
So it's quite distinctive, but doesn't always trigger an immune response. That's interesting.
Yes, exactly. despite being visible under a microscope, Giardia can sometimes escape the body's defenses, making diagnosis challenging.
This helps me understand how these infections look and behave. Thanks for breaking it down.
And what it may be, it's just an area. Here we're looking at a subcutaneous biopsy site where collagen has replaced most of the fat cells. Notice how those foamy histocytes are busily ingesting what's left of those fat cells. This process is part of the body's natural response to injury.
So these foamy histiocytes are like clean up crew members, and the arrows point to them eating the fat remnants. What about those golden yellow to brown granules mentioned in the inset?
Exactly. Those granules are hemosiderin, sign of prior trauma or bleeding. The body stores iron from broken down red blood cells in macrophages, giving them that distinct color. It's a clue for us pathologists to understand the history of the tissue. And
that makes sense. So in figure 3.4, we see a dermal scar with dense pink collagen, replacing adnexal structures and displacing subcutaneous fat. How does this compare to what we just discussed?
Great question. In figure 3.4, the dense collagen is part of the scar tissue formation. The pink color indicates mature collagen, which has replaced not only fat, but also hair follicles and sweat glands, the adnexal structures. This shows how scars remodel the skin's architecture.
So both figures show tissue repair processes. Collagen replacing damaged or injured tissues. In figure 3.3, it's more about fat being replaced after trauma, while in figure 3.4, it's the skin structures being replaced by scar tissue.
Exactly. Both figures highlight the body's remarkable ability to heal itself through collagen deposition. However, in figure 3.3, there's still some fat present and evidence of ongoing cellular activity, the histiocytes. Whereas in figure 3.4, the process is more advanced with complete structural replacement. All right, let's dive into chronic inflammation. It occurs when there's repetitive or sustained tissue damage from things like trauma, lack of blood flow, toxins, infections, or autoimmune issues. Over time, this leads to changes in the body tissues.
Wait, so chronic inflammation is about long-term damage. Like, it doesn't go away quickly?
Exactly. The body tries to heal through increased vascularity or fibrosis. But sometimes these attempts don't fully restore the tissue. This can result in tissue destruction or even obliteration of normal structures.
What's a macrophage? I remember hearing about it in immune cells.
Macrophages are crucial immune cell. They develop from monocytes, which circulate in the blood. These monocytes come from myeloid lineage. Part of your bone marrow's granulocyte and monocyte groups. And so today we're discussing how monocytes play a crucial role in our immune system by transforming into macrophages once they exit the bloodstream.
I remember that macrophages are found in tissues. Could you explain how they differentiate into various types?
Certainly. Monocytes can become organ-specific resident macrophages like microglia in the brain, Kupffer cells in the liver, and alveolar macrophages in the lungs.
That's interesting. What happens when they encounter inflammation?
And they become activated macrophages known as histiocytes. These can form granulomas, appearing as epithelioid cells or foamy cells, depending on what they engulf. Additionally, macrophages can fuse to become giant cells, such as Langerhans cells or foreign body type giants, each with unique nuclei arrangements. All right, let's dive into histiocytes. These cells have a very unassuming appearance, which is actually quite fitting given their name, tissue cell. Under the microscope, they look almost like they're blending into the background.
So, what do they look like exactly?
Histiocytes have pale pink granular cytoplasm, which sometimes contains chunks of material they've ingested. Their cell borders are indistinct, making them easy to overlook in tissue samples.
And their nuclei. What do those look like?
The nuclei are pale with crisp outlines, oval in shape, and often feature a groove. In fact, when you see a group of histiocytes together, their nuclei tend to form a circular pattern, almost like they're swimming in a barrel.
That's an interesting analogy. So, in tissue samples, they look like an easy to miss pink area.
Exactly. And when it comes to foamy macrophages, these cells are a bit more conspicuous. They're packed with lipid debris or organisms, giving them a distinctive signet ring appearance.
I think I need to visualize this better. Can you describe the overall work of histiocytes in tissue?
Today, we're discussing inflammation and the role of various immune cells in the body. And
I remember that inflammation can be acute or chronic. Even, could you explain how lymphocytes fit into this?
good question. Lymphocytes are key players in chronic inflammation. When they're present along with neutrophils, it indicates both acute and chronic inflammation.
So in the gastrointestinal tract, we use terms like active instead of acute. Why is that?
It would be part in GI conditions. Active refers to ongoing inflammation with lymphocytes and neutrophils, while inactive means only lymphocytes and plasma cells are present without neutrophils.
What about eosinophils? I've heard they're related to allergies.
Eosinophils have a bilobed nucleus and big red granules. They're linked to immune responses like allergies or parasites.
How do histiocytes fit in? I'm not entirely sure about their role.
Histiocytes appear as pale folded nuclei with light pink cytoplasm. They're often found in areas of inflammation, And their presence can indicate ongoing immune activity. All right, let's take a closer look at figure 320, which shows a histopathology slide of herpes infection. Notice how the nuclei are molded and have a peripheral rim of chromatin. This is different from the neighboring lymphocyte with its pale chromatin.
So why does the infected cell's chromatin look so different compared to the lymphocyte? I'm a bit confused about what these changes mean.
Great question. The changes in chromatin structure are indicative of cellular stress or death due to infection. In herpes, we often see nuclear alterations like glassy inclusions replacing the normal chromatin. This is a key sign of viral activity within the cell.
I'm still not entirely clear on what causes these specific changes. Is it something the virus does directly, or is it the cell's response to infection?
It's a combination of both. Herpes viruses like to modify host cell nuclei to facilitate their replication. These changes, such as glassy inclusions and altered chromatin distribution, are part of the viral strategy, but also reflect the cell's attempt to manage the infection. All right, let's dive into granulomatous inflammation. And this is a specific type of chronic inflammation that forms aggregates called granulomas, which can give us important clues about the underlying disease.
So, what makes granulomatous inflammation different from other types of inflammation?
Great question. Granulomas are microscopic aggregates of histiocytes, and these are specialized immune cells that engulfed pathogens or debris. They're surrounded by lymphocytes and plasma cells, which makes this type of inflammation highly organized and specific.
I remember reading about necrotizing and non-necrotizing granulomas. Can you explain the difference again?
Absolutely. Necrotizing granulomas involve tissue death or necrosis, which often points to an infectious cause like tuberculosis. Non-necrotizing granulomas, on the other hand, don't have this tissue destruction and are more commonly seen in conditions like sarcoidosis.
And what about caseating granulomas? I think caseating refers to the appearance, but I'm not entirely sure.
Exactly. Caseating granulomas are a type of necrotizing granuloma where the necrotizing tissue has a cheese-like appearance under the microscope. This is strongly associated with tuberculosis, as these lesions are characteristic of Mycobacterium tuberculosis infection.
So if we see caseating granulomas, usually means TB, that seems like a key diagnostic clue.
Yes, that's correct. But remember, while caseation is highly suggestive of tuberculosis, other infections or conditions can also cause necrotizing granulomas. The histological features and clinical context are crucial for making an accurate diagnosis. All right, let's dive into the fascinating world of granulomas. These are clusters of immune cells that form in response to infections or inflammation.
Wait, I'm a bit confused. What exactly are histiocytes again?
Good question. Histiocytes are specialized immune cells that engulf pathogens. They're the key players in forming granulomas. In conditions like Crohn's disease, the granulomas are small and not very obvious under the microscope. They often have a ring of lymphocytes around them.
So they look different depending on the disease, like in sarcoidosis.
Exactly. And that's just sarcoidosis granulomas are large and well organized, forming whorls of cells. It's quite striking under the microscope. And then there's tuberculosis and fungal infections. Here, the granulomas form a layer around pools of dead tissue or necrotic debris. This is often seen with special stains. Giant cells, while helpful in diagnosis, aren't always present. Over time, old granulomas can become hyalinized and lose their cellular structure. All right, let's dive into this fascinating topic of granulomas in surgical pathology. Now, I want you to pay close attention because understanding these structures is crucial for diagnosing certain conditions.
Okay, Professor, I'm ready. But first, could you clarify what exactly a granuloma is?
Absolutely. A granuloma is a collection of immune cells that forms uh, in response to infection or inflammation. In this context, we're comparing them to those seen in Crohn's disease.
I see. So how do these granulomas differ from the ones in Crohn's disease?
Great question. That these granulomas are often more substantial and easier to recognize compared to those in Crohn's disease. They appear as like well-defined masses of pink histiocytes.
Histiocytes. I think they're a type of immune cell. But could you elaborate?
Yes, histiocytes are specialized cells in the immune system that engulf and destroy pathogens. In these granulomas, they appear as pink masses under the microscope.
And those multinucleated giant cells you mentioned,
What exactly are they? Um, it would multinucleated giant cells, as the name suggests, have multiple nuclei. They're occasional features in these granulomas and are often highlighted by their arrowhead-like shape. Today, we're discussing how specific organisms like fungi are identified under a microscope using particular stains.
so, Professor, what exactly do these stains tell us?
Great question. Fungi, for instance, appear bright pink with the periodic acid shift stain and black with Gamouri's methenamine silver stain. These colors help us distinguish them from other organisms.
Interesting. But why is it important to know if fungi are invading live tissue or just hanging around dead cells?
Because that determines the severity of infection and treatment approach. Invading viable tissue suggests a more aggressive infection, unlike colonization of necrotic debris, which might be less severe. Looking at figure 3.8, we see caseating granulomas in tuberculosis. The center is necrotic debris while histiocytes are at the periphery. In figure 3.9, hyalinized granulomas show old collagen, indicating chronic infection. Size and staining help identify yeasts.
So the combination of size, color, and tissue context is crucial for identification.
Exactly. And each detail provides clues about the organism's role in disease. Take a look at figure 3.9, which shows a hyalinized granuloma. Notice the amorphous area of hyalinized collagen. This likely represents old, burned out necrosis.
I'm not entirely sure I understand what a granuloma is. Could you explain that again?
A granuloma is a collection of immune cells that forms in response to infection or inflammation. And so over time, these can become hyalinized, meaning they're replaced by tough collagen fibers.
So the amorphous collagen area is just scar tissue from old necrosis. Why does it look so different?
Exactly. And the collagen appears amorphous because it's been remodeled during the healing process. This indicates that the initial damage has healed, leaving behind fibrotic tissue. It's like a scar on the inside.
So this figure shows an area where the infection has been fought off and the body has repaired itself, but there's no active infection anymore.
Yeah, that's right. The term burned out suggests that the infection or inflammation has caused damage that the body can't fully reverse, leading to this hyalinized appearance. All right, let's dive into this. When looking at fungal organisms under the microscope, especially on H&E staining, there are some key differences between Candida and Aspergillus that stand out.
I remember hearing about yeast forms in hyphae, but I'm a bit fuzzy on the details. Could you break it down for me?
Absolutely. Candida species appear as round to oval yeast forms and can also exhibit pseudohyphae. These are often found in the debris at the epithelial surface, which is clearly shown in figure 3.11.
Looking at figure 3.11, I see magenta pseudohyphae and yeast forms labeled with arrows. That makes sense. How does this compare to Aspergillus?
Great question. Aspergillus species are quite distinct. On H&E staining, they appear as long, thin hyphae with 45-degree branching and septations. They can form a solid fungal ball or be scattered as single hyphae in the tissue, as seen in figure 312.
In figure 312, I notice a dense network of branching hyphae. How does treatment affect their morphology?
Treated Aspergillus may exhibit changes in their structure, but the key identifying feature remains their characteristic branching pattern at 45 degrees. This helps differentiate them from other fungi like Candida.
So to summarize, Candida is a round yeast form in a pseudohyphae near epithelial debris. Aspergillus equals long hyphae with distinct branching. Got it.
Exactly. And always remember that the staining method like PAS or GMS can highlight these structures differently, helping in their identification. In figure 312, we see aspergillus under a GMS stain, revealing a forest of branching hyphae.
What exactly is the GMS stain, and how does it help visualize aspergillus?
GMS, or Graham's modified stain, helps differentiate fungi. It highlights chitinous cell walls, making hyphae structures like those in aspergillus stand out clearly.
Why is the branching pattern of hypha important here?
Um, the branching allows efficient nutrient. This structure also aids in pathogenicity, helping aspergillus colonize host tissues effectively.
So the GMS stain helps visualize how aspergillus absorbs nutrients and possibly infects hosts through its branching network.
All right, let's dive into the fascinating world of fungi. Today we're focusing on two important types, mucor and zygomycetes.
I've heard about these bread molds before. What makes them unique?
Mucor and zygomycetes have irregular wide non-septate hyphae. So imagine they look like tree branches, gnarled tree branches with thick, hollow spaces. This structure is crucial for their identification.
Why are they almost invisible on H&E, but visible with PAS?
On H&E, mucor's hollow spaces blend in, making them hard to spot. Paz stain, however, binds to their chitin, revealing their characteristic purple hue. Now let's discuss macrophage histoplasma, a tiny yeast often found in macrophages.
How does it appear under different stains?
Histoplasma is delicate, about 2 micrometers, and appears as dark spots on Giemsa, but in silver stained granulomas, they're larger, around 5 micrometers. All right, let's dive into Cryptococcus. These are usually encapsulated yeast forms with narrow-based budding. They can be found either inside macrophages or free in the tissue. On a GMS stain, their sizes can vary, and some may appear collapsed into squashed balls, as shown in figure 315.
Wait, so the size variability is actually a key indicator of Cryptococcus? That's interesting. How does that help in identification?
Exactly. Like, the variation in size and their ability to collapse into squashed balls make them distinctive under microscopy. Additionally, specific stains like mucocarmin, fontanamacin can highlight the capsule of Cryptococcus, which is crucial for differentiating it from other yeasts.
But what happens if Cryptococcus loses its capsule? How does that affect identification?
Good point. If the capsule is lost, it can make identification more challenging. However, other morphological features and staining methods can still help confirm the diagnosis. Looking at figure 3.13, we see mucor stained with PAS. Notice the thick, hollow, irregular outlines of the hyphae. This is characteristic of mucor species And in figure 3.14, we observe histoplasma under GMS stain. The tiny yeasts are visible, demonstrating their typical appearance. All right, let's talk about tiny yeasts. Did you know they can be seen under a microscope using something called GMS stain?
Wait, what does 40 times mean here? Is it the magnification?
And then the 40 objective means we're looking at them under 40 times magnification. It's like a close-up view to see these tiny organisms clearly.
Why use GMS stains specifically for yeasts? I thought there were other types of stains.
GMS stain is great because it highlights the yeasts, making them stand out. It's particularly useful in chapter 3, where we discuss infections and inflammation caused by these microorganisms. All right, let's dive into this. So we talking about Pneumocystis gyrovesi, which used to be known as Pneumocystis carini. It's a yeast organism, and under the GMS stain, it appears black.
Wait, so if it's a yeast, why does it appear black on GMS? I thought yeast usually don't stain the same way as bacteria.
Good question. Yeast cells have chitin in their cell walls, which is why they take up the GMS stain so well. Bacteria, on the other hand, typically don't have chitin, so they don't stain the same way.
Got it. So, pneumocystis is found in the alveoli and has this flattened contact lens shape. I'm trying to visualize that. What does figure 316 show exactly?
Looking at figure 316, you can see these flattened organisms in the alveoli. They're not visible under H&E staining, but they're usually accompanied by a foamy pink exudate, which helps in their identification.
So why isn't H&E useful here? I thought H&E was pretty standard for detecting most pathogens.
H&E staining doesn't highlight yeast cell walls effectively. Plus, the exudate they produce is more visible with other stains like GMS. It's a good reminder that different organisms require different staining techniques for proper identification.
Makes sense. Now, what about bacteria? The text says most bacteria aren't identified by stains alone. Why is that?
Exactly. With bacteria, we often only get generic descriptions like gram-positive cocci in clusters. Without culturing them, it's hard to identify the specific species. There are exceptions with some hard-to-culture bacteria, but generally, stains alone aren't enough.
So if we can't rely on stains for most bacteria, why do we even use them?
Because they give us a starting point. For example, knowing it's gram-positive tells us which antibiotics to consider. But for precise identification, we still need cultures or molecular tests. All right, let's take a closer look at figure 3.16, which depicts pneumocystis organisms in the lung tissue. This photograph was taken using the same magnification power as figures 3.14 and 3.15, making it easier to compare.
So all these figures
are at the same scale.
that should help in understanding the relative sizes of different organisms.
Exactly. Now looking at figure 3.16, you'll notice that the pneumocystis organisms appear significantly larger than some of the other structures we've examined. They also exhibit a wide range of sizes and shapes.
Wait, why do they show such variation in size? Is it because they're at different stages of development?
That's a great question. The variation could indeed be due to different developmental stages, or even the angle and plane of sectioning during microscopy. Additionally, the GMS stain used here highlights their structure beautifully.
GMS stain? I think it's a type of special stain that helps in visualizing specific components, like glycogen or other carbohydrates. Is that right?
Yes, the GMS stain is particularly useful for demonstrating fungi and other organisms with carbohydrate-rich structures. It provides excellent contrast, making it easier to study their morphology.
So in this figure, we're seeing how pneumocystis appears under GMS staining compared to other methods. That must be really helpful for diagnosis.
Absolutely. This image is part of the Practice of Surgical Pathology textbook, which emphasizes the importance of understanding diagnostic processes in surgical pathology. All right, let's talk about necrotizing granulomas. These are a key sign of mycobacterium infections like tuberculosis.
Why can't we see the organisms under an H&E stain?
Good question. The H&E doesn't show mycobacterium because these organisms have a unique lipid composition that regular stains miss. They might be sparse too, especially in immune-competent patients. And that's where the acid-fast bacilli AFB stain comes in. It highlights mycobacteria in bright red, making them stand out against unstained tissue.
So, how do we spot these tiny bacilli under the microscope?
You need at least 20 times magnification. At 40 times, they look like red lint scattered across the slide. It's crucial to scan thoroughly to confirm infection.
What if AFB comes back negative, but we still suspect TB?
Then the aramine rhodamine stain is more sensitive. It uses fluorescence though, so you'll need a special microscope. All right, let's dive into this. So we're talking about Mycobacterium avium intracellular, which is a pathogen that primarily affects immunocompromised patients. When these bacteria enter the body, they get engulfed by macrophages. Those are the immune cells that usually eat pathogens. But here's the kicker. Instead of being destroyed, MAI multiplies Funkongna within those macrophages.
Wait, so the macrophages end up being overwhelmed? That's why they're called foamy macrophages.
Exactly. And the macrophages become filled with these mycobacteria, giving them a foamy appearance under the microscope.
And now in the duodenum, this can mimic Whipple's disease quite closely.
How do you differentiate between May and Whipple's disease then?
Good question. With a PAS stain, Whipple shows histiocytes stuffed with cranberries, which are actually periodic acid shift positive macrophages loaded with carbohydrates. But in MAI infection, you'll see fine rods instead.
Got it. So the AFB stain would also be positive for MAI.
Yes, exactly. The acid-fast bacillus or AFB and the stain will come back positive in MAI cases. Now, shifting gears a bit, Helicobacter pylori is another important bug we should discuss.
Right? It's the main cause of gastric ulcers. What does it look like histologically?
And you'll see a chronic inflammatory infiltrate in the stomach lining. There are some neutrophils mixed in, but overall it's more of a lymphocytic infiltration. Today we're discussing infections in different parts of the body and how to identify them under a microscope. Let's start with H. Pylori, which is commonly found in the antrum. So
I remember H. Pylori is linked to stomach ulcers. But can you describe what it looks like under a Diff-Quick or Giemsa stain?
great question. On the stains H, that pylori appears as tiny seagull-shaped bacilli in clusters. They're barely visible at 20 times magnification and can be found in the pit lumens or on the surface.
Seagull shaped. That's a helpful analogy. Can you show me what that looks like under the microscope?
Now let's discuss actinomyces. It forms a puffball bacterial colony and is usually harmless in the console, but significant in endometrial infections, especially with an intrauterine device.
Why is it more concerning in the endometrium? Is it because of its location or something else?
Exactly. And in the endometrium, actinomyces can cause invasive infections, unlike in the tonsil where it's unremarkable. The H&E stain shows a granular gray-purple cloud with filamentous structures.
The description sounds like a histopathology slide. Can you explain what that looks like compared to normal tissue?
Lastly, let's touch on viruses. DNA viruses like HSV and CMV cause visible cytopathic effects in the nucleus, unlike RNA viruses, which affect the cytoplasm.
So we can identify viral infections by looking for changes in the nucleus. That's an important distinction.
This helps in diagnosing conditions like herpes or cytomegalovirus infections, where nuclear inclusions are a hallmark feature. All right, let's dive into the fascinating world of microbiology. Today, we're focusing on RNA viruses and their unique characteristics.
Wait, Professor, hold on a second. The source text says the RNA viruses do not. Do they mean RNA viruses don't have DNA? I'm getting a bit confused here.
Great question. Let me clarify. RNA viruses, as their name suggests, use ribonucleic acids or RNA instead of deoxyribonucleic acid as their genetic material. And this is a key difference from DNA viruses and bacteria. You know, like Mycobacterium tuberculosis, this
Oh, I see. So RNA viruses don't have DNA. But how does that affect their replication? And what about the AFB stain mentioned in the text?
Excellent follow-up.
The acid-fast bacillus stain is used to detect Mycobacterium species, including M. Tuberculosis, which causes tuberculosis. The tiny wine red rods you see under a microscope at 40 magnification are the bacteria themselves. This staining method helps in identifying them because mycobacteria have a unique waxy coat that makes them resistant to typical staining techniques.
So RNA viruses and Mycobacterium are both pathogens, but fundamentally different in their genetic makeup. It's pretty interesting.
Today we're discussing herpes, simplex virus, and cytomegalovirus, CMV. HSV causes significant tissue damage and ulcers. When examining infected tissue, where should we look for the virus?
In the epithelial cells adjacent to the ulcer, right? Because HSV primarily.
Exactly every time, once inside, these cells become multinucleated. The nuclei transform and mold into each other. Can you describe what happens next?
The chromatin is pushed aside by glassy nuclear inclusions filled with viral proteins, creating a dark rim around the nucleus.
Correct. Now comparing this to CMV, which can cause similar ulcers but without obvious localized damage. Where does CMV tend to infect?
It infects epithelial, endothelial, and mesenchymal cells more broadly, making it harder to pinpoint.
When examining an ulcer, it's crucial to look at the ulcer bed rather than the surrounding area. And here's why. Certain viruses like CMV and HSV that it include cause specific cellular changes that are key indicators.
What makes these viral infections appear different under the microscope?
Great question. These viruses enlarge cells, making their nuclei more prominent. Inside these nuclei, you'll see a distinctive dark, dense inclusion surrounded by a pale halo, all within the nuclear membrane.
So if I see large, smudgy, dark nuclei among non-cancerous cells, should I think of CMV? And how reliable is this method?
Exactly. Finding such nuclei suggests CMV, but includes immunostains can confirm it, but recognizing these features early is vital for treatment. Now, let's shift focus to Helicobacter pylori. So,
I see these bacteria in the pits of the gastric mucosa. Why do they appear here? And what makes them look like that?
Pylori thrives in the stomach's acidic environment, burrowing into the mucosal pits. Its spiral shape allows it to penetrate and survive. Actinomyces, another bacterium we'll look at next, forms unique branching filaments that help in its identification. All right, let's delve into this fascinating topic. Have you ever encountered a filamentous ball of organisms that closely resembles fibrin? It's a common occurrence in surgical pathology.
Wait, I'm not entirely sure I understand. Could you clarify what you mean by filamentous ball of organisms?
Um, a filamentous ball refers to a cluster of elongated thread-like organisms that form a tangled mass. In this context, they resemble fibrin, which is a protein involved in blood clotting and tissue repair.
So, it's something that looks like fibrin, but isn't actually fibrin? That must make it challenging to diagnose.
Exactly. This resemblance can lead to overlooking or misidentifying these organisms. It highlights the importance of careful examination in surgical pathology. All right, let's talk about some interesting parasites we come across in the duodenum. I want you to picture this. And there's a parasite called Giardia that looks like a flounder with a long tail. From above, it appears kite-shaped, but from the side, it resembles a flat crescent.
Wait, so it's shaped like a kite when viewed from the top. That must make it pretty distinctive under a microscope.
Exactly. And here's the kicker. You won't see Giardia unless you're specifically looking for it. It tends to attach itself to the luminal surface of the villi, and while it doesn't usually cause much inflammation, it can be mistaken for debris. But look closely, and you might spot its unique eyes, which help in identifying it.
So, if someone sees what looks like debris but has these eyes, that's Giardia. That's, I should remember, that visual clue for identification.
Exactly. Now, another parasite you should be aware of is Cryptosporidium. It's also found in the duodenum, but primarily affects those with compromised immune systems. And what makes it interesting is how it clings to the brush border of the intestinal cells, like tiny bubbles sticking to a surface. And that
Are these clinging bubbles much smaller than an epithelial cell's nucleus? I need to visualize this better. Maybe like comparing something microscopic to a cell structure.
and that's right, you know. And Cryptosporidium is considerably tinier. So if you can do that, your Cryptosporidium is, you might have to look carefully. It's another reminder of how important it is to examine samples thoroughly under the microscope. All right, let's discuss some important viral infections. Figure 320 shows a herpes infection with classic nuclear changes. These include multiple molded nuclei surrounded by a peripheral chromatin rim and a glassy inclusion, nearly replacing the chromatin.
Wait, I'm getting a bit confused here. What? Can you explain what glassy inclusion means?
Of course. The glassy inclusion refers to a dense area within the nucleus that appears almost like a clear glass-like structure. It's a key diagnostic feature of herpes infections.
That makes sense now. So it's like the nucleus has these molded shapes with this glassy center.
Exactly. And in figure 321, we see a CMV infection. This endothelial cell shows a central reddish dense nuclear inclusion surrounded by a clear halo and a rim of purple chromatin.
Interesting. So
The CMV inclusion is different from herpes because it's red and cause that halo around it.
Yes, precisely. The central reddish inclusion with a clear halo is characteristic of CMV. These nuclear changes are crucial for diagnosis in histopathology,